Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is part of our Cancer Center series, which is a special collaboration between the Blum Center and Cancer Center. Before we get started, I just want to go over a few items with you all. Please note that today's program is being recorded for educational purposes. If you're interested in viewing the recording, you can visit our Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for our guest speaker, please use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, co-hosts, and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to introduce you all to Devin Punch. She is the health educator for Mass General Cancer Center, and she is going to introduce you all to today's guest speaker.
Thank you, Amy. Thank you, everyone, for being here today. And a big thank you to Dr. Reynolds and Dr. Santamarina for being here. Now I'd like to introduce you, and then you can take the floor. Dr. Kerry Reynolds is an oncologist at the Mass General Cancer Center. She is an assistant professor of medicine at Harvard Medical School, and she currently serves as the director of the Severe Immunotherapy Complications Service and the clinical director for inpatient cancer services. She joined the Harvard Medical School faculty in 2014 after completing her residency and chief residency at Mass General Hospital and fellowship training in oncology at Dana-Farber Partners Cancer Care. Dr. Reynolds is also joined today by Dr. Regina Santamarina, a family member of a patient with firsthand experience of these conditions. Thank you so much for being here today. We're very grateful that you're providing your unique and personal perspective on this. And now I'll turn it over to you. Thank you.
Thank you, Amy and Devin. And it is really such a pleasure. I want to thank the Blum Center and the Blum family. This is such an opportunity for me to speak directly with patients and family members and the public. So I'm excited today to talk about the black box of immunotherapy, how we are working to understand the side effects. And as Devin mentioned, I'm going to be joined by Regina Santamarina, who is just an inspirational individual. And I can't wait for you guys to get to meet her and has a unique perspective as a patient's family member. So what I hope at the end of the hour that you leave with is an understanding of how these new cancer drugs work. What is the mechanism of action of the novel immune checkpoint inhibitors? In addition, we'll review the side effects, what we call the immune-related adverse events, or IRAEs. We'll show you what an overview of the evaluation of an oncology patient who may have an IRAE related to immunotherapy looks like, and I'll also update you on some of the new research emerging for the management of patients with immune-related adverse events. So if we go back a decade, I think I want you to walk away with knowing that immunotherapy is a good news story. Because if we go back a decade, melanoma in 2011, unfortunately for advanced disease, we only had chemotherapy at the time and the response rate was about 5 to 20%. The agent we were using was dacarbazine and it only lasted, unfortunately, months. So you didn't get years and years of treatment response. So if you had a melanoma with lymph node involvement, unfortunately, the average overall survival was 12 months. If it had spread or metastatic to the lung, it was down to 8 months. And if it had spread to the liver, the bone, or the brain, it was down as low as 4 months. So a really, really bad prognosis. But if we look at melanoma just last year, because of these new immune checkpoint inhibitors and novel therapies, you can see that ipilimumab, which is the first drug approved, one that we'll talk about, has an overall survival when they looked at the most recent trial out 4 years of over 34%. In addition, the newer agents, the PD-1, is over 40%. What this means is we have truly bent the survival curve. These patients are living out with durable remissions. So this is just a graphic that shows on the y-axis survival, on the x-axis time. If we do nothing in advanced cancer, unfortunately, it's shown here on the blue, that time can be very short. If we use our conventional therapies like chemotherapy or even targeted therapy, we can get increased survival, but unfortunately, the tumors often become resistant. Whereas with immune checkpoint blockade, that's the purple bar, we actually get these durable responses. And because these agents were so effective as single agents, the field has started to use combination therapy to get even higher effect. So that's shown in this dotted red line here. So an immune checkpoint inhibitor might be combined with another immune checkpoint inhibitor, or with chemotherapy, or with targeted therapy. So really combination is here to stay as well. And this is not, when these boxes show up, you don't have to read the fine print. It's just to show you how far we've come in a decade. That first agent was approved in 2011. That's ipilimumab for melanoma. And in 2014, you can see we had 2 additional agents approved. But since that time, we have had now over 50 FDA approvals. These approvals are in over 15 types of cancer for 8 different checkpoint inhibitors. So the field has exponentially grown. And you know how I said we are starting to do combinations? The dark blue show how many approvals are now combination therapy. And you can see that is much more common in the recent years. And so immune checkpoint inhibitors are here to stay. And why is that? Well, it's because they're having very effective responses in a subset of individuals in these tumors that are historically really difficult to treat. And so you can see the tumors and you can see the response rate anywhere from over 50% to melanoma, over 30% in lung cancer, 40% in kidney cancer, and so on. So this is quite an exciting field. So how do these drugs work? So this is going to be an immunology 101. But many times a day, your immune system has to recognize self versus non-self. Meaning self, is this a part of my own tissue, or non-self, being a foreign pathogen that the immune system needs to attack? And so it does this because there are little pieces of tissue called antigen that are displayed on this purple bluish cell down below. That's the antigen presenting cell. That's displayed up on a MHC molecule. Up to the pink cell here is an immune cell called the T cell. It is connected with the T cell receptor, and right here, this is signal 1. Now your body has to say, if this is self, the immune system needs to stand down. Whereas if this is non-self, there needs to be a second signal that fires to get immune activation. That second signal is shown right here with CD28 on the T cell and CD80 on the antigen presenting cell. So when that signal alarms, off to the races the immune system goes. And the T cell can proliferate, it can start to secrete cytokines, which are signal molecules, and it can start to migrate throughout the body looking for that antigen. And that's how we keep ourselves healthy from an infectious standpoint. However, there needs to be brakes on this system because we don't want unregulated autoimmunity or inflammation. And so the brakes are oversimplified here, but you can see one of these brakes is CTLA4, one of these brakes is PD1 and its ligand, PDL1. And the cancer center drugs that we're talking about actually interfere with these brakes. So they inhibit these brakes so that the immune system can stay activated, can stay alert, and so that the adaptive immune system can then recognize the tumor and destroy it. You can see the agents that are approved here, not that you have to be able to pronounce them by the end of this talk, but it's nivolumab, pembrolizumab, and cipilimumab that are PD1 inhibitors. The oldest drug approved was a CTLA4 inhibitor, which is ipilimumab. And then the PDL1 agents, you can see we have multiple approved as well. So these are how this drug works. They basically interfere with the checkpoints, hence why they're called immune checkpoint inhibitors. But remember, those checkpoints were for a reason. It was to make sure that we don't have dysregulated inflammation. So we can't be that surprised then when all of a sudden when we were using these drugs, again, the conditions over to the left in black, you don't have to be able to see each one. Those are just what we reported that we have seen here. But they can cause inflammation of your regular organs at times. And so that can be inflammation of the bowel, that's colitis, or inflammation of the liver is a hepatitis, of the lungs, it's pneumonitis, of the various endocrine organs. It can affect the heart or the kidneys. It can affect bone marrow. the joints or the skin, the neurological system, or the eyes. So you can really see we can get inflammation in any of these conditions and any of these keys. And this makes it really important when we see a patient that has had immune checkpoint inhibitor that comes to their doctor, whether it's their oncologist or their primary care or their emergency room. We really all have to be aware of these agents because of the fact something as simple as fatigue. Fatigue in a cancer patient can have many different causes, but fatigue when you've had an immune checkpoint inhibitor has a wide differential. So is that fatigue because the heart isn't working that well? That would be myocarditis. Or because one of the endocrine organs is involved? Could it be related to liver dysfunction or just global rheumatic conditions? We've had multiple conditions like polymyalgia rheumatica or giant cell arteritis that have been reported. Could it be neurologic? Because sometimes that can also lead to a feeling of overwhelming fatigue in terms of myopathy or neuromuscular conditions. And then sometimes we rule out all of that stuff and it is not related to inflammation of the organ. The therapy itself can cause fatigue. In addition, with our cancer patient, we always have to worry, is it disease progression or is there another medical condition like an infection or something else going on? So you can just kind of see how we have to evaluate these patients from top to bottom. When we see these patients and when we think about the immune-related adverse events, we all have to speak the same language. That language is grading the toxicity. And when we look online, CTCAE, the common terminology criteria for adverse events, is the grading we use. And I wanted to show you this so then we can talk about how common, say, grade 1 events are versus the more serious grade 3 and 4. So using this criteria, grade 1 is mild or asymptomatic, meaning we don't have to intervene. Grade 2 is more moderate. So all of a sudden we have to start to think about intervention. And I see most often being inpatient, grade 3 or 4, which is severe or even life-threatening consequences can be indicated. So urgent intervention is required. And at all costs, we try to prevent grade 5, which is death related to adverse events. So that helps us. Now that you know the grading, we can know how frequent are these events. When we think about any toxicity, which is the box over to the left, you can see those rates look high, anything from 74% up to as high as 90% if we combine 2 checkpoint inhibitors together. However, I will say most are mild, very well tolerated. And for any of those who have known a cancer patient that had chemotherapy, they definitely have toxicity as well across the board. So we have to put that into perspective. But what we really kind of hone in on then is how many have severe events, say grade 3 or 4. And when we think about those, it can be up to 14% with the single agent PD-1 inhibitors, or even up to over 50% with the combination. So this is something that we are seeing and that we continue to see more often as more approvals have been accepted through the FDA. I always like to think about that third box though, who really had a severe event enough that they had to stop treatment. And you can see those numbers are decent as well, anywhere from 6% of the PD-1s, 21% of the older ipilimumab CTLA-4 inhibitor, or 38% if you start combining these things together. And on the right is very important in terms of the death. This isn't death from cancer or death from another reason, it's death from immune-related adverse events. And that ranges a little less than 1% to just over 1% of patients. But why is this important? Well, it's because we are estimated, right? I showed you all those FDA approvals. It is estimated in the US alone this year, we are going to treat over 233,000 patients with these drugs. And so if we think about something that happens severe grade 3 or 4, anywhere from 14 to 38% of the time, we're talking about anywhere from 23,000 to 69,000 individuals with serious immune-related adverse events diagnosed in the US alone. And that is multiple fold higher than, say, the number of leukemic patients we will diagnose this year alone. So this is something that is evolving, that has been evolving over the last several years. And this is just the US numbers, whereas obviously this is a global drug. And I can give you those little stick figures that show different patients, whether they're gray or they're blue, but the reality is that doesn't tell you what it's like to be at the bedside of these patients. So I'm going to give you a case, a 47-year-old gentleman that I was able to meet. So if we go back, it was April 2016, started having right shoulder pain. It just so happens that it was actually liver that was radiating that pain up to where he was feeling it. This is an MRI over to the left here that shows the lesion. It's an area of enhancement in the liver. I kind of circled it in yellow. And we needed to biopsy that liver to figure out what exactly was causing the pain and what the mass was. The biopsy was consistent with cholangiocarcinoma, which is a cancer of the bile ducts. The standard of care therapy is 2 chemotherapies combined, which are gemcitabine and cisplatin. And so we started the very next month. Unfortunately, though, like many patients with cholangiocarcinoma, his disease progressed within just by November of that year. So he had progressive disease. We knew we needed to do something else. That's when he enrolled on a clinical trial with a checkpoint inhibitor and a new molecule. And unfortunately, within 2 months, he ended up at the Mass General Hospital. He was having low oxygen, that's hypoxia, infiltrates in the lungs, so meaning both of his lungs, there were clear infiltrates, and his heart was not functioning correctly. The ejection fraction is the squeeze of the heart, and his was down to 45%, where normally you should be much higher than, say, even 55% or higher. When we did all of our evaluation, because infiltrates in the lung could be anything to do with the lung, or it could be fluid that is backing up because the heart is failing, and that's what his was. So he had myocarditis, inflammation of the heart causing heart failure, and related to nivolumab. We started immediately with immunosuppressive therapy, and he did well. He was able to get out of the hospital, and that next month when we checked his liver lesion to see how it was responding to therapy, it had actually had a slight decrease, which was incredible. However, the following month, in March of that year, his heart was okay, so his ejection fraction was back up to 68%, but he was readmitted with increasing elevated liver function test, diagnosed with hepatitis. We had to go do a liver biopsy to determine what the elevated liver function test was, and it was inflammation related again to the PD-1 inhibitor, the nivolumab. And that was not just his only immune-related adverse events. 3 months later, the immune system started to attack his bone marrow. Despite everything, we tried steroids, we tried CellCept, we were trying multiple different immunosuppressive lines, but the immune system did keep attacking. And so he became transfusion dependent, needed blood, needed platelets. And because we had had him on steroids so much of 2017, he actually developed extensive compression fractures in the back due to osteoporosis from chronic high-dose steroids. So much so that we had to use cement or kyphoplasty to help the bone fractures. And so really significant, just showing how hard it can be with the treatments that we currently have, and unfortunately how in a case like this, they can be ineffective. Because despite everything we tried, he passed away from refractory toxicity related to immune checkpoint inhibitors. And I hope you get the sense of how hard we were trying and how little we actually know about these conditions. And so just to summarize that intro that we have started with, immune checkpoint inhibitors are clearly now standard of care. The success of the single agent immune checkpoint inhibitors have now led to combination approvals, and the field is moving fast. A subset of patients experience these durable long-term responses, and this is a home run compared to what it used to be like. But we have to be aware of the unique autoimmune toxicity profile, meaning all of these organs that can get inflamed. And they often happen early, so they often happen within the first 3 to 6 months, just like our case that happened at month 2 when it all started. But unlike chemotherapy, with chemotherapy, we can just stop drug and the nausea can get better, the diarrhea can get better, the neuropathy can get better. But unfortunately, unlike chemotherapy with immune checkpoint inhibitors, these can last. And if we don't intervene, the inflammation can actually progress and be even more concerning down the line. So we have to be aware and we have to recognize these events. And they can occur even after immune checkpoint inhibitors are stopped. And so the alert has to be high. Unfortunately, we still don't know the mechanism, meaning what is driving these events. The mechanism is just not well understood. Thankfully, often they are typically low grade, grade 1 and 2, but as we showed, severe immune-related adverse events, grade 3 and 4 can happen, and unfortunately, in worst case scenario, they can be fatal. Now, since this time, we have seen a whole host of guidelines that have come out, but they are not evidence-based guidelines. These are the best treatments we can put together right now, but we really need a better understanding of what is driving these conditions. When we think about some of the earlier guidelines, it was ESMO, which is shown here on the left, or the Journal of Clinical Oncology, also published on the right. And I am so excited to be giving this talk in July because of the fact that hot off the press. So we had spent several years with older guidelines, but just recently on the left, we have updated guidelines from the National Comprehensive Cancer Network, the NCCN. And on the right, just June 25th, the Society for Immunotherapy of Cancer also came out with new clinical practice guidelines. They are very similar to previous though, because the evidence base still needs to be developed. And so how do we manage them? Well, if they're mild, if they're grade 1, we can actually often keep treating, meaning we can treat symptomatically. Whereas if they're grade 2, if they're getting into the moderate category, then we have to really think about, do we need oral steroids to suppress the immune system? And so we often use prednisone at 1 mg per kg. This is individualized based on the type of toxicity though. So importantly, for example, the endocrine organs, if you have thyroid inflammation, or even if the pancreas has caused a type 1 diabetes, we just replace the hormone. We do not have to use steroids in the endocrinopathies. But for grade 3 or 4, progressive, severe, or life-threatening, the other inflammation in the other organs, we have to hospitalize these patients and begin high-dose IV steroids until they can get under control where we can switch over to an oral dose. And then we taper very slowly, as I'll show you later. And then if steroids do not work, unfortunately, it is an absolute black box. So we have to reach for second-line immunosuppression with very little evidence to know which agent might work. For some, we use mycophenolate mofetil, which is also CellCept. That's what we used in the case of the 47-year-old. Or in the case of, say, refractory colitis, we think about infliximab, which is another immunosuppressive agent. But I'm just trying to explain how much we have still to learn. And then it takes not just oncologists to care for these patients, because even if we look at those guidelines and we say, okay, we're reading through the guidelines exactly how to manage these patients, you will see often if there are any conditions, we need to bring the subspecialists in. So if there's a cardiac condition, we need the cardiology consult, or GI, you can say here for pancreatitis or for grade 2 colitis, we need to bring them in. You can also see neuro, nephrology, pulmonary, rheum, endocrine, hepatology, dermatology, you name it. But because these can affect so many different organs, we really need to work closely with subspecialists who know about these conditions. And so awareness there is also important. And so after that case, obviously, it was very challenging, and we had seen an increasing number of patients that were being admitted second to severe immunotherapy complications. And so I sat down and really just drew bubbles and thought, what would it take to organize around this group of patients so that 1, we can perform the best clinical care possible, and 2, that we can really start to understand these from a clinical and translational research specific program. And so if we look at all these bubbles, really all they are is pulling from oncology. At a highly academic centers like ours, sometimes places are siloed. And so we needed to make sure we had the melanoma doctor, the lung cancer doctor, the breast cancer, the GI, you name it, all together. In addition, we really needed to cover our bases across the organs, because I just showed you how many consultants we need to call on. And so over time, we've developed the severe immunotherapy complication service. We transcended the normal traditional kind of departmental boundaries and formed something that is unique, that we all have a common mission and a common goal. We started seeing patients together October 3rd, 2017, and we now have 51 members across 6 different departments and 10 divisions of medicine. And it is so fun to learn with this group because we're constantly learning from each other. We meet every other week so that we can review our cases, so that we can talk about the research projects and the gaps that still exist. And importantly, it's not on the clinical side only. Over to the right, you can see my partner in crime, Dr. Chloe Villani. She is a scientist. She has been a genomicist, immunologist, and also heads our single cell center here at Massachusetts General Hospital. And Chloe has dove into really understanding these from a basic science standpoint. So we think about blood and tissue getting to the lab, and then the 15 individuals under her, you can see actually go back and forth between the clinic and the lab. We have anywhere from a rheumatology fellow trained, a gastroenterology fellow has trained, cardiology fellow, endocrine, oncology. So we're really trying to think about how this can also be a training ground to teach the next generation about precision medicine. And we think about clinical care, that's the central circle. The patient is always our North Star. We think about clinical research, and there is a registry now of all the patients that we treat here at the center, as well as a translational effort where we collect those samples to get them to the lab, which is going to be key for really understanding what drugs should we be pulling from the shelf. And so again, when I talked about that 47-year-old, it's easy to say these are cases and there are increasing number of cases, but every case to us has a story. And at that time, we didn't have guidelines. We didn't have some of the same answers. And this is Dr. Rodrigo Santamarina, who was that 47-year-old patient. And I just had to step back and say, did he have a predisposition to have these severe side effects? Why was his condition so refractory despite we tried everything? We even tried multiple agents. And what was underlying it? Why was it that it was the heart involved, then the liver involved, and the bone marrow? And what is really driving these adverse events or diseases that we're seeing? How can we develop diagnostics? Because we had to biopsy often, and not every center can biopsy like we can here. And so how can we develop better diagnostics and better best practices to treat these patients? And what other treatments could we be using? So I think it is so key to realize who inspired all of this. And Rodrigo was certainly one of those patients. And I have Regina Santamarina here with me today to tell a little bit about what her experience through all of this was like as well. I'll hand it over to you, Regina.
Thank you. Good morning, and thank you for joining this presentation today. I need to start by saying that for me, it is an absolute privilege to be able to share my story with you. And in doing so, I represent, and I am doing this on behalf of all the patients and all the families who have been part of immunotherapy clinical trials or who are receiving at this point immunotherapy. I met Dr. Reynolds when Rodrigo was diagnosed, not diagnosed, but when we were involved in the clinical trial. So to put, like she said, a face in these cases, I am going to let you know a little bit about Rodrigo, my husband. He was 47 years old when the devastating diagnosis of advanced cholangiocarcinoma, we had to face this diagnosis. He was at the peak of his professional career 6 months after we had opened a private practice of plastic reconstructive and hand surgery. He was also an artist, self-taught artist who found this talent a few years behind. He used to tell me that when he retired, he was going to paint. Fortunately, one day he thought he did not need to wait for retirement, came home with canvas and started painting and created a lot of beautiful paintings that today are a reminder of his personality. But honestly, the title that was the most important title for him was not being a plastic surgeon, even though it took him 13 years to train and to be able to practice as a plastic surgeon. That was his passion. The title that meant the most to him was being a dad. We have 2 kids who are now 18 and 17, and were 15 and 14 at the time of his passing. So let me tell you what all that Dr. Reynolds explained about those conditions and those inflammations presenting. We would run to our emergency department in Pittsfield, Massachusetts. That's where we live. They would evaluate him and immediately transfer, when possible, when he was stable enough, to Mass General. In Mass General, he received the best care possible at the time. But again, there were not a lot of answers. So everybody was trying to do their best. And everybody that knew about this even if it was just a little bit, would put in his input into treating him. The most important message that I would like to leave with all of you today is what immunotherapy meant for us. After going through chemotherapy, we knew that chemotherapy could only do a little bit. And when given the opportunity to join the clinical trial for immunotherapy, we didn't even thought about it. That was our best choice. That was the best path that we could take. Immunotherapy gave us hope. And I really want you to think about it. Hope in the midst of going through all this devastating inflammations and running and being hospitalized for more than 100 days, hope was the source of our strength. Not only his strength, but my strength and our kids' strength to keep pushing. Because like Dr. Reynolds mentioned, the tumor was shrinking, so the immunotherapy was working. So we kept saying to ourselves, if we can only find a way to control these reactions, we already have the cancer under control. Now we just need to fight all these adverse reactions and keep them under control. Unfortunately, at the time, we were not able to do so. But that inspired this extraordinary physician, who's Dr. Reynolds, to create this team and put it together in order to start looking and finding all the answers that needed to be responded. I cannot express with words, honestly, the gratitude that I feel for the creation of the severe immunotherapy complications team and their effort to find those answers. They are enthusiastic and tirelessly have worked in order to find the answers. I've had the honor of being present in the meetings that they have, and the energy that you feel inside that room, it's uncomparable. They are all so invested into trying to find these answers, and they've advanced so much. And again, for me, it's a privilege to join them and to watch how step by step these questions have been answered. As a patient and as a patient and family advocate, I wholeheartedly and without any reservation, not only support, but applaud all the efforts in the research projects so that one day we will be able to predict, to minimize, and hopefully to avoid the adverse reactions. So then that hope, that precious gift of hope, will be given to more patients and more families, and hopefully with a better outcome. I'm going to end by saying that if I could turn back time and we would get offered the immunotherapy trial again, we would do it. No doubt in my mind that we would go through that again, because it gave us the most precious gift that a family facing cancer can receive: hope. Thank you very much for having me here today and listening to my story.
And Regina, thank you so much, because you have given so many gifts by kind of walking with us through each step of the way and through each year. So thank you for sharing that. It's really important that I think we realize that we have such an exciting time with immunotherapy, but we really do have to figure out the side effects as well. So thank you for joining us today. And I loved how Regina put it, because she talked about incremental kind of discoveries. And I think that's what's so important is the group that has come together, because we have a central patient registry, meaning we're trying to understand all of the patients that we treat with immune checkpoint inhibitor and those that get immune-related adverse events. We have actually now have over 90 different projects that went to publication, and they are small windows into how we are going to figure out these individual organ system toxicities. Because of time, I can't share them all with you, but I just want to share a couple because I think it helps frame where we are headed. And so the cardiologist down at the bottom left is Tom Nealon. That's our cardiologist as part of the severe immunotherapy complications program. And I think this was so important because, like I said, the treatment and how much immunosuppression we should be using or how little is one key aspect that needs to be personalized. And so he pulled together 23 sites, so not including just our own heart inflammation cases, but also cases from 23 sites. And when we looked at how they were treated, you can actually see different doses of steroids. There are 3 different groups of patients that you see over to the right. 16% of them were treated with just low dose steroids, meaning less than 60 mg per day. Whereas there was a group of about 43% that had something in the middle. So they were diagnosed from anywhere to 60 to 500 milligrams a day. And then there were the high dose patients, because once we started realizing the low dose wasn't working, we started to use higher doses in myocarditis or heart inflammation. And so there was a high dose group that about 39% were in. And we wanted to see which dose really is most effective. In addition, I showed little clocks over to the right because we were looking, what if you gave this therapy less than 24 hours? So really right off the bat after diagnosis versus 1 to 3 days, which is the second group, about 27% got it in that window. And then 38% of the people in the study had it over 72 hours afterwards. And what we're looking at for outcome is how many patients developed what we call major adverse cardiac event, or MACE. And that is major, meaning it's cardiovascular death or cardiac arrest or shock, or a significant enough heart block that you require a pacemaker. So what percentage? You can see here in the low dose steroid group, 61% of the patients that were treated with low steroids developed these major cardiac events. Whereas in the intermediate group, it was 54%, and in the high dose group, it was 22%. So it was so clear to us from that standpoint that high dose steroids for the win. And that really has evolved the practice, not just here at Massachusetts General Hospital, but across the nation and the globe. In addition, early steroids for the win. And what I mean by that is this graph is just showing the first finding of high dose steroids. This is a MACE-free for survival, meaning you want to be at 100% here. And high dose was clearly best. In addition, the time to steroids less than 24 hours was clearly much better than the time to steroids if we gave it between 1 to 3 days, or if we gave it over 3 days. And so this just highlights the importance of how people have to be able to recognize this, because early treatment and the right treatment is critical for outcomes. So that is one example where we showed we needed to actually not use just the regular dosing that is in the guidelines, but we found that we needed to do a higher dose that informed the guidelines. And then we have a different scenario. So let's take the scenario of a 51-year-old male with stage 3 melanoma. He was on adjuvant nivolumab. Adjuvant means this patient was not metastatic. It was not in a metastatic setting. It was in a potentially curative intent setting. And that's the drugs are moving earlier and earlier in hopes to decrease the chance of relapse. And he just developed some fatigue, some chills, some night sweats. In clinic, his creatinine, which is a marker of acute kidney injury, was elevated to 1.69 from his normal at about 1. The office gave him some fluids, they repeated it, it wasn't better. So they checked it again in 4 days, and at that time it had increased to 2.9. So we needed to be admitted to the hospital for acute kidney injury. These are his labs, and really I only show it to show the little red arrows of kidney function were abnormal. The LDH is a non-specific marker that was slightly elevated, but otherwise he was actually doing well and quite healthy. That meant we had to figure out his acute renal failure. And so we did a core biopsy that showed severe inflammation. So a severe inflammatory infiltrate. That's when we knew we needed to think about the dose of steroids. So he was given Solumedrol and then a prednisone taper. This is an oral prednisone taper that we went down by 10 milligrams each week. And you can see he needed to be on steroids for 60 days total. And this just shows how well he did. So the creatinine is the measure of kidney injury, and it came down beautifully, meaning he came back to normal. But this blue bar shows how long we had to taper those steroids to be in accordance with guidelines. Again, it was great that he improved to baseline within 1 month. He had rapid improvement. He had actually halved his creatinine by day 5, and he was completely at baseline by day 20. And he was discharged home on hospital day 4. And so when we think about, I'm going to switch over to when we think about the study that we did to start to think, does everybody need that long of steroids? We thought about trying to think about the patients that may be able to come off steroids more quickly. A creatinine is really easy to check, so it's easy to stay on top of. And so we started a protocol with permanently discontinuing any AIN-associated medications, meaning any inflammation-associated medications, ones that can cause kidney injury by themselves. Prilosec or a PPI is one of them. Allopurinol, NSAIDs or ibuprofen or Motrin, those had to be discontinued, as well as antibiotics. This important rapid taper protocol was led by the two individuals you see below, and the study overall was led by Dr. Megan Seiss. And she began the prednisone at 1 milligram per kilogram per day. But then if they were doing better in 5 to 7 days and had decreased by 25%, we rapidly tapered them off the steroids, repeating that creatinine as we went to make sure that they were doing well. And at the MGH Cancer Center, we had 45 patients treating both of these different ways, meaning one kind of standard with that long 60 days of prednisone versus one with a more rapid taper. And the important findings between the two groups is that the rapid taper group, here shown on the left, 85% recovered within 2 months, within 60 days, as well as the standard of care, 64%. So our rapid taper did not hurt anyone. They didn't do worse, which was good. The median time to renal recovery, meaning how fast they got better, was about 11 days in the rapid taper versus 36 days in the standard of care. And if we look at when they could get drug again, it was about 26 days. So they obviously, if you taper them more rapidly, they can go back on their cancer therapy if they resolve. And it's about 135 days in the standard of care. So this kind of is just showing you that we're trying to titrate, one, what is the right drug? We're not so certain it's always going to be steroids, but it is steroids for now. And then making those incremental improvements, just like Regina said. With high dose, we know we need to treat that for myocarditis and even brain inflammation, encephalitis, whereas some of the conditions we can actually taper more rapidly. So a lot of research is still to be done, but this is just showing that the patients in the darker blue, the rapid taper patients, did do well. And so additional ongoing study is in the midst, but I think that it's just important of how we all come together. And why study these events? Well, they're hard to diagnose, and we need to develop better diagnostic tools. At this point, we have very little to help us with diagnosis. Often here we have to biopsy the tissue that might be implicated, and you can't biopsy every tissue in the body. The treatment is limited to withholding immune checkpoint inhibitor or giving steroids, and so we have a long way to go to finesse that. And we need to identify biomarkers. If I knew Rodrigo was going to have that severe of toxicity, could we have started drugs earlier that could mitigate the toxicity? You know, could we have thought differently about his treatment that we gave him? And so there's just an enormous need to identify these biomarkers and develop better therapies, and specifically predictors of who then is safe to go ahead and re-challenge after you have an immune-related adverse event. So what we're doing in the lab then is we're sending blood and tissue. So if a patient goes for these biopsies or gets an analysis with blood, we also send that to the lab if they consent, and patients are incredibly generous. It's really amazing to be able to work at the bedside of these individual patients that are okay and happy to advance research. And so if we think about a liver biopsy, then we dissociate these cells from the liver, and we can isolate every single cell with novel techniques like single cell RNA sequencing and analysis. And the real goal down below shows you there's a healthy state. So we know certain cells are in any specific tissue. And then we're looking at the disease state in hopes that we can pick out, say, these ones that don't exist in the healthy state. Maybe then these are the culprit cells, and we can then design treatment paradigms to go back in to a target more the disease state only. So a lot of work being done in the future. I'm gonna kind of move over to questions after I just give this one last statement. I was so lucky to be able to have cared for Rodrigo, and honestly, about 3 weeks before he passed away, he was admitted at an outside hospital, and I was able to call him, and I said, Rodrigo, you know, we have all these bubbles together. We're going to bring all these people together. We're going to have a central registry, and then we're going to really start to crack the science open. And he was a physician as well. And I just thought it was really neat to be able to connect with him and tell him about the efforts. And I remember on the phone, I wrote it down actually word for word, but I said, what you're going to do is going to benefit so many. I'll be happy and honored to participate or help in any way possible to make this journey easier for others. That will make mine even more worthy. And so I think when you have that kind of inspiration, you know, you can't go wrong. And of course, you got to meet Regina, but Regina said at the same time, I feel exactly the same. If our journey helps someone else's be less painful, then it's even more worthy. If awareness was created, then what we endured has more meaning. This is how science advances. This is how we learn. This is how medicine writes the new chapters. I hope God gives me enough years to witness the progresses that I am sure the MDH team will achieve. He will remain alive in that progress. And one day my kids will have one more reason to be even more proud of their daddy. You can tell they have a 17 and an 18-year-old. We're still convincing both of them to go into oncology. Clearly, there is a lot of work to be done. And so we are excited to be able to do that effort. It takes an army. I am so thankful that Regina was with me here today, as well as for Amy and Devin in the invite, and for all of you that are joining. And I look forward. I wanted to stop early enough to make sure we had time for questions. I have much more I could talk about if there are no questions, but I'll hand it back to you, Amy and Devin.
Thank you so much, Dr. Reynolds. This was exceedingly informative, and it was wonderful to hear from Regina on the patient family aspect. We do have a couple of questions that have come in. What is the role of pharmaceutical companies in the study of immune-related adverse events? Are you partnering with them?
That's a really great question. So as we know, all of these immune checkpoint inhibitors are all FDA approved. They are all pharmaceutical agents. Just to give you a sense of the field, in 2017, immune checkpoint inhibitors globally were a $17 billion business. In 2025, it's estimated that it will be $56 billion business. The issue is that currently much of the research is being done on the efficacy side, meaning how well do they work? How well do they work earlier lines of therapy? How well do they work in combination? And very little is being done on the immune-related adverse event side. And so as part of this, about a year ago, we started to partner with the FDA and with pharmaceutical companies, as well as a central platform called Project DataSphere, to try to bring all the stakeholders together. And I really do feel like the pharmaceutical companies are starting to understand the importance of this and treating these as unique diseases that occur in the setting of immune checkpoint inhibitors. And so our hope, we're in discussions with one to think about a clinical trial to treat myocarditis. And so the hope is really that we can move forward as a partnership to study both the toxicities as in addition to the efficacy. So a work in progress, but right now it's definitely under-resourced.
Thank you. That's a lot of exciting work going on, important work. What does black box treatment mean exactly?
Yeah, that's a good question. So when we think about black box or gray box, it's like an area where we can't see into it, meaning we just don't have the evidence yet to be able to clearly know what we need to do next in medicine. And so the issue is more along the lines of, if steroids are not working, where do we go to next? Meaning, how do we treat these underlying conditions, and what second line immunosuppression agent should we use? So it's really just an area of unknown or a black box in that setting that is not yet understood.
Is dosage a precise study, or is it more trial and error?
That's a really good question. And I think that probably refers to dosage of, it could be one of two things. It could be dosage of the immune checkpoint inhibitor, or it could actually be dose of the steroid. So let's take them both. So if we take the dose of the immune checkpoint inhibitor, early studies, remember the first drug was ipilimumab, and ipilimumab was studied at either 3 milligrams or at 10 milligrams per kilogram. And when we think about the 3 versus the 10 was actually highly toxic. And so the 3 milligram was chosen to go forward. And even so, even in some of the more recent approvals, down to 1 milligram of the ipilimumab is chosen to go forward in combination. And so those doses are not just trial and error for the immune checkpoint inhibitor. They have been done in clinical trial and really rigorous study and trying to choose the most benefit with the least toxicity. Now, on the other side, you might be saying about the dosage of steroids, for example, meaning the dosage to treat immune-related adverse events. And you could not be more right that 1 mg per kg, that means, say, for a 70 kilogram individual would be 70 milligrams a day, and then we taper that by 10 milligrams each week. That is very empiric. We do that for a host of other autoimmune conditions, so kind of borrowed from that context. But really why I tried to highlight at the end, that's not the right dose in myocarditis. We actually need more. And it might not be right to taper it so long in things like nephritis or inflammation of the kidney if patients are doing well. And so the dose is empiric right now. We are trying to fine tune this to get it a bit more personalized, but oftentimes for most conditions, the 1 milligram per kilogram or the empiric dose does work.
A couple more questions coming in. Is immunotherapy a long-term treatment option? Are there any breaks or holidays in between treatments?
That is such a great question as well. So immunotherapy was studied in different ways. For example, pembrolizumab, if you have a complete response, no evidence of disease, many of the studies in pembrolizumab stop at the 2-year mark, meaning, you've already, the immune system is woken up. That was the main goal of the therapy. And so they stopped therapy because that was written in the clinical trial. Whereas there are immunotherapy trials that did not have a stopping point. And so in those, it's really hard to know, do we extrapolate from other data or do we keep going? So it's a really important discussion with the oncologist, the patient. And you are exactly right that toxicity may sway that, because if someone is not handling the drug very well, but they have a great response, that could then make us want to do a holiday for sure in that patient. And then if for some reason the disease recurs or gets worse or spreads to a new spot, that's when immunotherapy might have to come back in. The one thing I will note about that, though, there are some toxicities we are very cautious about ever re-challenging. In fact, our guidelines would suggest that we should not re-challenge. Some of those conditions are, say, pneumonitis or inflammation of the lung. If it was a very severe pneumonitis, people get very worried about re-challenging. Similarly, if there's a very severe inflammation of the heart causing, say, a MACE, a major adverse cardiac event, we get very concerned about re-challenging those patients, and some of the neurological toxicities. And so the way we think about re-challenges, thankfully in this group with a lot of subspecialty expertise, and we can really work together on a case-by-case basis, but often it's for the less severe toxicities, those we feel comfortable re-challenging, or the severe toxicities that really respond very well and to steroids only. Some of the others get a little bit more dicey, and so we really need that subspecialty expertise to kind of walk through that with the patient.
Thank you. A bit of follow-up to the dosing question. Is toxicity stable or does it decrease or increase over time under the same dosage?
Yeah, good question. So toxicity is stable, and in fact, it's stable and early. So oftentimes for toxicity, if you're given a dose, whether it's 3 milligrams or 10 milligrams, meaning the most events occur within the first 3 to 6 months, and then they start to drop off, meaning it's far less frequent to be occurring later on. However, I will add that some of the initial data, when we looked at dosing, it's called pharmacokinetics. And if we look at just the PD-1 and the pharmacokinetic dosing, we found that even if you just give a couple doses of immunotherapy and then you try to look, how long did that immunotherapy, that monoclonal antibody, these are all monoclonal antibodies, how long did it stick to the PD-1 receptor on the T cell? And we found that over a year out from the last dose, that still 60% of the receptors were saturated, meaning that the T cells are actively engaged and still ready to go. And so we can still see late toxicity, but the majority, again, they're stable in terms of the toxicity, but they happen relatively early. They can happen late, so we have to have a high suspicion.
Given that these are new conditions, what is being done to describe them? Are they exactly like other conditions that you've seen?
So that's really the crux of having a central patient registry. And if you want to jump on the website, it's actually also on in the deck. But as far as the description of these conditions, it's so important that we first just describe the spectrum of what we are seeing. And so many of our publications to date have been just that, meaning really understanding, for example, in heart inflammation, it can be as simple as, say, just an asymptomatic patient that might have one cardiac enzyme number that is elevated, all the way to the patient that is very severe, and very severe in that they have a cardiac adverse event, they might develop shock, might need to be in the CCU. And that spectrum has been now described. And that was one of the most important parts of the effort. And then you have to say, well, this is inflammation of the heart. You know, there is viral myocarditis, meaning where viral illnesses can cause inflammation of the heart. Is this the exact same or is this different? And we find that this disease, unfortunately, 46% of patients with myocarditis related to checkpoint have a very serious outcome, whereas that is not the case at all with viral myocarditis. So we know this is not the exact same condition. This is a much more virulent form. And so that was just one example of how we did it with heart, but we've really done it across the board with types of toxicities. And a lot of that work is kind of key because you got to describe it first, and then you have to define it. And so that's the next major effort that we've been embarking on, is really describing the definitions for which to call these cases so that we can pull the cases together and understand the outcomes related to that. And so we just went through a major definitions project as well that will be soon out in JITSI.
Another question that's come in is long-term steroid management similar in immuno-related adverse events to that of other specialties? For example, rheumatology has a lot of practice in controlling side effects with long-term steroid use.
So you're exactly right. It is the same, meaning the effects of steroids are the same on our patients as they are in the other indications. For example, like you said, rheumatology, or some of the interstitial lung diseases have long-term steroids. So there are other conditions for which have long-term steroids. And in fact, I will say that they have a bit more of a regimented follow-up on their patients because of the fact that they're looking for bone health, they're looking for calcium, they're looking for vitamin D, because steroids we know can cause osteoporosis like it did in the case that we described. In addition, steroids can cause hypertension, can lead to infections, can lead to weight gain, swelling, things along those lines. And so I actually feel like those disease centers, we can borrow a lot of that same management as they are doing. And that's kind of what we have borrowed from so far. I think at the beginning, oncologists didn't think we had to do necessarily that same level because of the fact that we were going to taper off and be done. But we know in some of these instances that just is not the case, and our patients require more long-term management. And so it's a work in progress, but so far that is what we have been doing, is borrowing from a lot of the other diseases that have had this longer term.
Thank you. Looks like we have time for one last question. What if we want to learn more about immune-related adverse events? Where can we go to find accurate information?
Yes, so I struggled with this a bit as well. All of us did, because we have patients in all of these different subspecialties with the different conditions. And that specialist always has a long, drawn out conversation with the patient about what this is, what are the chances, as well as thinking about what the treatment and the workup is going to look like for these patients. But we couldn't find that anywhere for patients. And so actually about a year ago, we published a book. It's called Facing Immunotherapy. It's available on Amazon as well, but it is really robust. I think there's 26 chapters where each person around the wheel took their condition and really kind of outlined how likely is this to happen? What is the natural history? In addition, we even put in that, what is it like to be on a clinical trial? Or what is it like to think about supportive care, meaning what other things you may need as we traverse these immune-related adverse events. So that is one option. And then most recently, I looked again to see what else might be out there. The Society of Immunotherapy for Cancer, so SITC, SITC, just recently did put together a little video for immune-related adverse events for patients. So that was the only other real kind of patient-facing documentation that I saw. But so those are some of the key aspects. And again, I think the book is really written in an educational way that could be good for frontline providers, could be good for patients or families alike.
Thank you so much again, Dr. Reynolds. This was absolutely wonderful to hear about all the amazing work that you're doing. Do you have any final words before we finish for today?
I just want to say thank you so much. And I hope that you see that this is kind of a work in progress. It is a hope, just like Regina said, and it's not even hope, it's durable long-term remissions for many patients. So this is a good news story. We just really feel like there needs to be more attention and funding on the other aspect of it. So a work in progress, but meaningful work. Thank you.
Thank you so much, everyone, for joining us today. And as Amy mentioned earlier, the recording will be posted to the Blum website. Have a great rest of your day.
Thank you. Take care.
Thank you.
Bye, guys.